Hello everyone and welcome to the new topic on oral epithelial neoplasms. Under this we will be discussing the benign tumors first. So the linear outcomes under the DTS curriculum are as follows. By the end of this topic, the student should be able to define neoplasia, explain the difference between benign and malignant tumors of epithelial origin, classify the various benign tumors of the epithelial origin, and explain their clinical features and histopathological features of oral papilloma and oral nevi. Okay, so let's look at what is a neoplasm. So the definition that is accepted is the definition that is given by Willis, which mentions that a neoplasm can be defined as an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissue and persists in the same excessive manner even after the cessation of the stimuli that evoked the change. All right. So the key words here are that a neoplasm is an abnormal mass of tissue, right? Number one, and then that it exceeds the growth of normal tissue. And the most important aspect is that it persists with the same excessive manner even after the cessation of the stimuli. So an example for this would be, for example, lung cancer, which has been initiated, okay, because of smoking being an etiology. Once lung cancer has developed, if you stop smoking also, the lesion will not stop, right? So that means it has already become malignant, it has become neoplastic, and thus the lesion will persist in the same excessive manner even after the cessation of the stimuli. Okay. So this is a brief animation to show you. So for a neoplastic lesion to actually develop, you just need one mutation to take place in one single cell, and that one single cell multiplies and leads to the formation of a tumor. Okay. Right. So now tumors are classified into tumors of epithelial origin and connective tissue origin. Further, they are classified as benign tumors of epithelial origin and malignant tumors. All right, and we also have a similar classification for connective tissue tumors, which is benign tumors and malignant tumors. Now, in between the spectrum of benign and malignant, there is also a term of premalignancy. All right, that means lesions which have a higher tendency to actually turn malignant. And this particular concept has various different terminologies and taxonomies that have evolved over the period of time, and we will discuss them in subsequent lectures. Right, so let's now look at benign tumors, and rather two slides here that I'm going to discuss, where I'm going to discuss the differences between benign tumors and malignant tumors. So let's first look at benign tumors. So benign tumors are those which proliferate and divide but do not invade the surrounding tissues, number one. And number two, they do not metastasize. All right. So that is the difference between benign and malignant tumors. The growth of benign tumors is non-life threatening and their clinical course is usually predictable. Okay. Number three, they may cause problems due to pressure, obstruction, or excessive hormone production. So this is in general about benign tumors. So the most important thing, which I believe you already know, is benign tumors are banal and are not life-threatening. The reason being that they do not invade surrounding tissue and neither do they metastasize. Whereas, on the other hand, malignant neoplasms are neoplasms which invade and oblique or metastasize are called malignant neoplasms. Often the common term called cancer in ordinary language is actually used for malignant neoplasm. Their clinical course is progressive unless adequate therapy is available for the patient, otherwise the patient will eventually die of the disease. Okay, and malignant neoplasms, depending on their cell of origin, there is the prognosis can be determined based on their histological type, based on their clinical course, based on their staging and grading. Okay, these cancers show destructive invasive growth behavior and could produce signs and symptoms such as blood loss, due to ulceration and hemorrhage, pressure and destruction of adjacent tissues, obstruction or constriction of flow in vital organs. All right, they can also have metabolic effects such as general cachexia, which is severe weight loss, including reduction in muscle mass, which is very common in advanced stage malignant disease, and specifically production slash secretion of tumor specific products or hormones. Right. So malignant neoplasms, when you in comparison to benign neoplasms, are life threatening. Number one. Number two, they are invasive and they cause metastasis. Okay. So this is a slide image to just give you a perspective of the differences, right, between benign and malignant neoplasms. So to summarize, benign, they do not invade or metastasize, they're slow growing, they have low mitotic rate, they're clearly demarcated from the surrounding tissue. That means they generally have, they are encapsulated or have a pseudocapsule. Nuclear morphology is often normal. Mitotic figures or dysplastic features are not present. Okay. Clonal chromosomal abnormalities are not there. So that means the chromosomal number is normal. On the other hand, malignant tumors, they invade and metastasize. The margins are not demarcated clearly. The surface often is ulcerated and necrotic. Cut surface is heterogeneous. This is something to do with the gross appearance. Often high mitotic rate is seen. There's rapid growth. Microscopically, you see atypical features such as nuclear pleomorphism, hyperchromatism, abnormal mitosis, and at the chromosomal level, you see aneuploidy. Aneuploidy means abnormal chromosome number. Okay. Okay, so let's come down to benign tumors of epithelial origin. The most common one being squamous papilloma, which is our interest here in this topic. Okay, two main lesions that we will stress on would be squamous papilloma and oral nevi. So let's look at squamous papilloma first. So this is similar to this common skin warts. Okay, is the fourth most common lesion in the oral cavity. In the oral cavity, these squamous papillomas or oral squamous papillomas are caused because of human papillomavirus 6 and 11. Right now, this typing of the HPV is different for different regions of the body where a papilloma can develop. All right. Now, this particular viral virus 6 and 11, which affects which actually causes the oral papillomas, oral squamous cell papillomas, are of low virulence and low infectivity. So majority of the HPV oral infections actually are resolved by the immunity of the individual. 90% of them, 10% of them lead to oral manifestations. Okay. Now, usually oral manifestation is that of an exophytic growth with finger-like projections, which has a rough surface which resembles something that resembles the vegetable cauliflower like surface. All right. And it is well circumscribed and is most of the times is a pedunculated lesion. Okay. So these lesions are painless, pink to white in color depending on the amount of keratin that has been produced on the surface. They are common on the tongue, lip, buccal mucosa, gingiva, and the palate. This is a clinical picture of an exophytic lesion which has the rough surface and looks like a cauliflower-like appearance. All right, and this lesion is present at the on the lingual frenum. All right, on the lingual frenum. Now, histologically, these lesions present as long, thin finger-like projections, right, which extend from the mucosa made up of stratified squamous epithelium with thin central core of connective tissue. So I'm going to explain this further in the coming slides. So basically, there are finger-like projections, all right. So it's an exophytic growth, finger-like projections, which these finger-like projections are lined by stratified squamous epithelium with a central core of connective tissue. They may show hyperkeratosis. So if it's hyperkeratotic, the lesion is going to appear white. If it's not keratotic, then the lesion is going to appear pink. Okay. Now, because these lesions are caused secondary to the viral infection that affects the epithelial cells, we specifically see some kind of special cells which are called koilocytes. Now, koilocytes are basically virus infected cells, and they They appear vesicular with pycnotic nuclei. So I'm going to show you what they are in the coming slides. So treatment for these lesions is surgical excision, and recurrence is seen. The recurrence here is seen because of the viral etiology of these lesions. Now this is the histopathology of squamous papilloma. All right. So if you look at this, this is the finger-like projection, and if you see this this histological image, it clearly correlates with the clinical image where the surface looks rough, right? And this is the finger-like projection. Inside the finger-like projections, you are actually seeing a core of connective tissue here as well. So this is a longitudinal section here. That's why you are able to see the core connective tissue inside, whereas here it is you have to imagine that you have to understand that histological slides are basically two-dimensional cuts of three-dimensional lesion, and that's why in these areas the entrapped connective tissue core actually looks like in the center, because in these areas those finger-like projections have been cut in cross section. So that's why the variation that you see here. So this is the histological image, okay, hematoxylin eosin stain slide. This is the surface keratin that you notice here, okay, the dark pink layer of excessive keratin. So if you ask me what color is this lesion clinically, the reason is white. It's white because of the excess keratin that is there, right? Now this is the diagrammatic representation to try and make you understand. So this is the base epithelium. So this is the exophytic lesion. This is the thin stalk here, right? This is the core, fibrovascular core, the finger-like projections lined by squamous cells, and the papillary projections, right? This is squamous cell papilloma. Right, this slide here we show you coelocytes. Now this is a collection of epithelial cells, and if you look at them, these cells, you see specifically some of these cells which are balloon-like, right, with a small short nucleus, pycnotic nucleus, right, and these are by HPV infected epithelial cells which are described as coelocytes. This is the same diagrammatic representation of the same. These cells are the coelocytes. Okay, so now I'd like to actually mention here, usually when I discuss this topic, I always bring this up for my students here. So this is an image of an interesting case of a person who had these massive skin warts, and these skin warts are different from the banal skin warts or the oral squamous cell papillomas that you have seen. So in these particular patients, there are very few of them around the world. This is a man from Indonesia who actually went on to develop severe skin warty lesions caused secondary to human papillomavirus, and some immune dysregulation, because of which this lesion, despite treatment, first of all, when it was small, when it was treated, it again recurred, and then every recurrence led to severe, more severe lesions, eventually leading to the person not being able to perform daily routine chores, and it's severely affecting the life of the individual. So what I'm actually trying to tell you here is that squamous cell papillomas, right, or papillomas that are caused because of human papilloma virus, they vary, and on the skin is a different subtype of the virus that causes it. Most individuals around the world, as I mentioned, 90% of those lesions are resolve or do not show any manifestation because of the immunity, but some very rare cases, the lesions are very severe and can lead to this kind of a presentation. This person was actually even called a tree man, because the presentation of these keratotic squamous these warts was so severe and so thick that, as I told you, it affected his normal life. Right. So this is just a piece of information for you. Okay, so now let's look at oral nevi. Now, first of all, oral nevi is also called oral melanotic nevi. Okay, they are benign proliferations of nevus cells. Now, first of all, before we move ahead, I'd like to remind you that when you have studied embryology, you would have read the embryological origin of nevus cells, and I would like to remind you that nevus cells are derived from neuroectodermal cells, right? And these nevus cells are present in the epithelial layer, the submucosal layer, or both. Okay, and whenever no these nevus cells they proliferate, have a benign proliferation, then they lead to the oral melanotic nevus. Now, as such, now these are classified as either junctional, intramucosal, or compound nevi. And nevi may also be classified as congenital or acquired. Okay, unlike the cutaneous counterparts, oral nevis are rare. Okay, so I'm sure on the skin you do know that nevis are commonly called moles, all right, or yeah, which are basically a collection of nevus cells that give rise to black or brownish color pigmentation on your skin, and many a time they are actually even identified as to be distinguishing marks or identification marks that you even document in certain applications and forms. Now, oral nevi, as we discussed, are classified as congenital, right? If they are small, under congenital you have small and garment. So the small congenital nevi are present at birth. They are greater than 1 centimeter but less than 5 centimeter in size. Garment nevi are large. Okay, they are present at they may be present at birth, all right, and if it's greater than 10 centimeters, then they are actually called garment nevi. Now, acquired nevis are nevis that develop in a child, an individual, as the individual matures, right? So through childhood to adulthood, if you develop nevis, then they are called acquired nevis. Right. Histologically, the classification for nevis is junctional nevi, compound nevi, and intradermal nevi. Now, I'd like to remind you that oral nevis, under the section of oral nevis, we do not have what you call garment nevis, right? And most of the oral nevis may be either acquired or congenital, but very small in size. Okay. Histologically, the oral nevis could be either of these three types: junctional, compound, or intradermal. Now this is a clinical picture of a patient here, right? So you're able to see a pigmented dark blackish spot on the hard palate. Now this is an oral nevi. Now before you actually come up with a diagnosis of oral nevi, you have to actually be able to rule out other pigmented lesions, all right? Pigmentations because of exogenous products or endogenous pigment, and then eventually once you've ruled them out and you've actually identified that it is because of the nevus cells, then only we call it an oral nevi. So clinical features, they're seen commonly in less than 40-year-olds, all right, more common in white women, all right. 40% are seen on hard palate, followed by buccal mucosa, vermilion border, and the gingiva. Now, differential diagnosis, DT here means differential diagnosis. You need to rule out ethnic pigmentation, amalgam tattoo, smoker's melanosis, vascular lesions, and malignant melanomas. All right, now ethnic pigmentation is basically pigmentation that is seen in dark skin individuals. That means Negroids, Asians, etc. do have darker pigmentation of the mucosa. But how do you differentiate oral nevi from ethnic pigmentation? Ethnic pigmentation is uniform and diffuse, all right, whereas oral nevi is a focal collection of nevus cells. Amalgam tattoo, on the other hand, is basically during an amalgam restoration. If amalgam is either exogenously embedded during the restoration into soft tissue, or leaching out of amalgam from a heavily restored amalgam restoration into the soft tissue, can lead to a pigmented lesion, which is basically amalgam, which contains amalgam. Now, it's very difficult to actually differentiate between amalgam tattoo and an oral nevi unless a histopathology is done. Okay, a histopathology is done. Smoker's melanosis again affects the hard palate and is common is seen specifically in heavy smokers. Okay, vascular lesions are basically lesions of endothelial origin, all right, and they are differentiated basically based on the color. So nevis, oral nevis are usually dark brown to black in color, whereas vascular lesions are usually red, blue, or bluish black in color. Malignant melanoma, of course, the size, the shape, the presentation varies, is more aggressive, and of course, it is actually the reason why we actually worry about oral melanotic nevus or melanotic nevi, right? Okay, so moving to the histopathology of oral melanotic nevus. So nevus cells, first of all, are large, ovoid, round, or spindle-shaped cells with pale cytoplasm and melanotic granules. Usually, these cells in the normal epithelium are seen in the basal cells. All right, and if there is a proliferation of nevus cells, you will see many of these present in the as a focal collection. Now, these nevus cells, their nucleus is vesicular. Okay, and if there is a focal collection of nevus cells and we're looking at an oral nevi, then it has to histopathologically be one of these three types. So intradermal is basically a collection of nevus cells within the epithelium, right? So the nevus cells are separated from the epithelium by a well-defined band of connective tissue, whereas junctional is when the demarcation zone is absent and there is a dropping off effect that is seen. That means this dropping off effect is basically an effect of these nevus cells from the epithelium moving into dropping into the connective tissue. And compound nevus is basically shows features both of junctional and intradermal. All right. So treatment for these lesions is surgical excision. Now, if there is a oral nevi in the oral cavity, it is recommended to be excised because local irritation, chronic irritation from restoration, from prosthesis, from various different sources in the oral cavity can give rise to a transformation of this uh, benign lesion into a malignant, although it is very very rare. Okay, so that's the reason dental surgeons usually recommend removal of a nevus if it is identified in the oral cavity. Okay, long-term follow-up is also. This is the diagrammatic representation to try and explain what do we mean by nevi here. So here, and the number one here actually shows you normal melanocytes. Okay, so this is how normal melanocytes look. So centrally placed nuclei, pale looking cytoplasm might have melanin granules in them. Now number two is junctional nevus. Now this is where there is focal collection of the melanocytes that's taken place over here. Number three is compound nevus, where there is collection of nevus cells in the epithelium as well as in the connective tissue. And number four, which is intradermal or intramucosal, where the entire collection is in the connective tissue. Okay. Now this is the histological image of the three types. This is junctional here. All right. This is junctional type. This is the compound type. Right. Last one, this is the intradermal type of nevus, right? So now these nevi, as I just mentioned, are if present in the oral cavity, are always recommended to be excised. Okay. Further on, we will go on to discuss this topic even in the case-based learning through the Google Classroom. So please go ahead and refer to the textbook for further reading, and if you have any doubts, please do not hesitate to contact me.